Hi, everyone.
Good evening.
Welcome. Thank you guys for logging on. We'll just give it a couple more minutes as you start to log in. Hi. Hi, everyone. Welcome. Hi, everyone. We'll get started in just a minute. I do have the chat function available. So as you're waiting, if you have any questions that you're ready to have answered, you can feel free to start using the chat to type in your questions. We also have information about how to contact Dr. Feliciano's office with either the phone number or the form to be contacted. So feel free to take a look at that as we wait. Hi, welcome. Hi, good evening. Okay, let's go ahead and get started. Hello, everyone, and welcome to our virtual patient seminar. My name is Lauren Landman. I'm a representative of Ortholine, a medical technology company. Today, we've partnered with orthopedic surgeon Dr. George Feliciano from Orthopaedic Associates of West Florida in Clearwater, Florida. We're holding this educational seminar to discuss the advancements in total knee replacement. And since the seminar is hosted on Facebook Live, all attendees are muted. So if you have any questions, you can feel free to type them in the comment section. That should be located either below your screen or to the right of this live video. I'll be notified once you place your questions in the chat, so I'll make sure we have plenty of time to get those questions answered. So again, thank you for joining, for being here. We're looking forward to answering your questions and learning a little bit more about total knee replacement with Dr. Feliciano. So without further ado, Dr. Feliciano, the controls are all yours.
Thank you, Lauren. Good evening, everyone. This is kind of a nice format to be able to reach more people than what sometimes we're able to do in person. So I thank you for your time. And hopefully we can make this really very interesting and as interactive as possible, despite not being in person. At the end, I would say as we go through, take advantage of the chat function to get your questions in. We'll try to tackle as many of them as possible because I think that's really the best way to get most of the information that can be catered to you. So I'm very thankful to be able to partner with Ortholine and share their technology that I use for my knee replacement surgeries. As Lauren said, my name is George Feliciano. I am an orthopedic surgeon, been in practice now for nearly 18 and a half, 19 years. It goes by really very fast. I specialize in joint replacement, both of the hip and the knee. Mainly attracted to that, mainly to try to get people back into the activities that they really love to do. We realize how essential one part of our body actually is when it's not functioning correctly. My background and source is really from the Midwest. I was trained in Indiana University for my School of Medicine. As you can see there, ventured out to Ohio and then specializing in joint replacement in California and La Jolla. So shout out to those people who might be logging on and have some connection to those places as well. I'm thankful to have joined a very dynamic group in Clearwater, Florida, Orthopaedic Associates, and they've welcomed me into their ranks and hope to join their highly specialized team in providing joint replacement. Our topics for today is really to try to make sure that we're on the same platform for what we're talking about and cover things like what is osteoarthritis, what kind of symptoms one can expect when they're having arthritis of the joint, particularly for tonight, we're talking about the knee. And then what treatment options we might actually have to take care of ourselves, as well as when you're actually seeking care with a healthcare provider, whether that be your primary care or coming to see someone like myself in the office. Additionally, on the surgical side of things, to broach the topic and introduce you to Lantern and OrthoLine's technology that assists me when I actually do my knee replacement surgeries. So what is osteoarthritis? I think sometimes the term gets a little bit generalized because people just think about that root word arthritis. And it does involve the joint, and it is inflammation and breakdown of our joints. Oftentimes it's summarized as that wear and tear type of arthritis. People will often experience that they just can't really do the things that they really want to do, whether that be walking, whether it be actually running, riding a bike, hiking, or even sitting comfortably and enjoying a show that a family member is participating in or their sporting event, because a joint hurts or it's too stiff and you have to get up and move, or rather you can't even make it up the stadium bleachers to find your seat. You tend to park in the closest parking space. You maybe have actually asked because of that knee pain or hip pain at times that you get a handicap placard. And oftentimes patients will tell me that for some period of time, they really haven't felt like themselves because they are taking these various conveniences, such as the elevator instead of the stairs. And they'll often say, well, I've always taken the stairs, but now I just really can't anymore. Osteoarthritis shouldn't be considered something that, excludes you from the world. And that, in fact, actually, it's really one of the most common ailments that actually plagues all of us all over the world. Osteoarthritis in particular, I alluded to, is that wear and tear arthritis, where we have the protective cushioning for the ends of our bones at the knee for the femur above and the tibia below. That protective cartilage layer is that cushion that protects the bone. Over time, much like any part that's rubbing and moving will wear out over time, and that is the ailment that we all will suffer as time catches up with us, as well as us enjoying life and doing the activities we want to do. When the bones actually start to contact one another or even come close to that, our body will respond by generating that inflammation with fluid, meaning swelling, which causes stiffness, may also hurt. And subsequently, the bones themselves may continue to wear down in more advanced cases. Now, despite all of the advances that we've actually done in healthcare, it's interesting when you think about that 1 out of 5 Americans over the age of 40 will actually suffer or be diagnosed with osteoarthritis. If you look at World Health Organization data, this data has also not changed in the years that I've even been in practice, that worldwide, it is actually about 21 to 22% of the world's population will suffer from osteoarthritis as a medical illness in their record as we age. So it is a big area that a lot of studies are doing, but knee replacement and current treatments are still out there to try to help us enjoy our lives. Early on in the spectrum of cartilage loss and damage, we'll actually see things that happen perhaps earlier in life or particularly middle of our life when we actually pick up a sport or an activity, where we start to get little pits, little defects, little dings, if you will. Oftentimes we can remember that for things that we were doing that my knee kind of really hurt for a period of time, and then it seemed to get better. Didn't think much of it after that. The cartilage, however, does actually take a bit of that beating, and we carry some of those bits of damage that we're not able to really repair. As it continues to affect more of the joint, we start to actually see that stiffness and decreased mobility, the increased pain, maybe the concessions that we actually may make just so that we don't continue to hurt ourselves. We give up those activities. Now, some of those things may be very rational. I think some of us might actually make more risk-taking behaviors, but as we age, I think we like to be human beings in motion. So tonight's topic hopefully allows us to continue to find our healthy mobile selves, so to speak. As we get into the really late stages and you involve the entire cartilage surface, this is where osteoarthritis really pulls ahead and starts leading the various list of causes of disability amongst both us here in America as well as really all over the world. Walking and traversing inclines, declines, sometimes even stepping off a curb becomes challenging, or at least people will tell me that they have to make a much more deliberate effort to make sure that that knee doesn't buckle when they step down off the sidewalk or getting out of your car. So in those cases, it's probably already time in which to have an evaluation to see where you are on the spectrum, or even if arthritis is actually your problem. We covered already that the symptoms that present with arthritis, which can be applied to really any joint in the body, where you have stiffness, swelling, and particularly the lower extremities or long limbs that we talk about, you may notice that actually your knees become more bow-legged or knock-kneed. And that's actually a little good segue in talking about alignment and how we're actually made. Some people actually have been bow-legged all their life, and they notice that their knee actually starts straightening, and it's because of where you're wearing out and your knee itself is becoming more arthritic typically. The pain that we have often will prevent those activities that we want to do, and sometimes it's as simple as just going and walking for exercise. For general fitness, we know that we need to keep moving. So when we start to try to make a decision for ourselves and what we want to do, you want to try to put it in your mind in regards to how much pain do you really actually have, and how would you classify those symptoms in regards to, is it electrical pain? Is it just a dull ache? Is it really only when I'm in bed? Is it just at first thing in the morning? So timing of which that those times that you actually experience it can be kind of important too to evaluate. Clearly, the more often that it actually impedes your daily activities, the more pressing and forward of mind it's going to be. And definitely those key factors you kind of want to keep maybe a running list of for when you actually go to the office to consult somebody about that. When we talk about treating osteoarthritis, I think we live in a time now where there really are a lot of different schools of thought as well as avenues to actually take. I like to divide it up into things that most patients and people who are cognizant of what's going on in their body and that we're breaking down can do for themselves. So I get the big question often is, will losing weight actually help my pain? And the answer to that probably is very logically yes, to a certain degree. Nothing is complete. In perhaps the earlier stages of arthritis, this may be the number one thing that somebody can actually do. A good piece of math, sometimes physics, maybe we don't want to engage in too much highly technical things, but weight loss, we can put about 3 to 5 times our body weight actually through our knees quite easily just with normal activities. So if somebody loses 5 pounds, I always tell them congratulations, that's 25 pounds of force they took off of their knee, the good knee as well as the bad knee that they may have. Exercise and continuing to do activities is still worthwhile. Even short physical therapy to learn exercises that you then can do on your own are very helpful. We'll often pick up a brace, maybe even use a cane for a short period of time, maybe even lean on our spouse or significant other in certain situations. And all those are valid to try to shield ourselves from more pain. Over the counter, we're very familiar and definitely are bombarded by a lot of advertisements for aspirin, Excedrin, Tylenol, all of the anti-inflammatories that you can field your fancy with to try to relieve pain, swelling, and inflammation. Topical over-the-counter analgesics are also available as well. And then definitely from your primary care or orthopedic specialist, prescription anti-inflammatories can be tried as well, although they shouldn't really be considered much stronger necessarily than the over-the-counter version, but yet they can affect people differently. Therefore, one person might actually say the prescription medication works for them better than Advil, whereas the other folks in line might actually say that Advil and naproxen over the counter have always been better than any prescription medication when it comes to the anti-inflammatory. So some experimentation, but consulting your doctor is worthwhile as far as that goes. Injections are available. This now like would most often come from your orthopedic provider, sometimes also rheumatologist, and a few primary care doctors may offer it as well. Steroids are a more potent anti-inflammatory treatment option to reduce inflammation, and its relief is usually temporary. How long it's going to last is actually much more dependent on your level of disease and sometimes on the patient's activities and how hard they are on that knee to begin with. So keep that in mind. Hyaluronic acid, or affectionately called gel injections, do actually, I think, provide a lot of relief, maybe on average about 50%, some people less, some people more. The relief can be more lasting, up to 6 months, sometimes more as well, particularly if you're on the earlier end of that spectrum. Not listed on the screen would be also some other treatments that have been around for a while that still haven't received the extensive, say, randomized clinical controlled studies, but that would be things like platelet-rich plasma or stem cells that I get questions about as well. And I think those have their place, but definitely would be an individual discussion to see if that's something applicable to each person with arthritis. If we delve now into surgical options, I will get questions often about, well, why do we have to do a total knee replacement? Why can't we just replace the part that's bad? And the answer to that is that we can. There are actually implants available to do partial knees, but I would say that it's a highly selective process in order to try to get real success from the surgery. As most people would probably agree with me that they wouldn't want to have even a partial knee replacement, knowing that in a short period of time, they might have to have another operation to change that to a total knee replacement. So although partial knee replacements are available, it too really needs to be treated as a very selective option for somebody with the right geography of disease within their knee, the right amount of severity, and definitely they should not have even mild to moderate arthritic changes in the other compartments of the knee. This slide is nice because it actually shows those three geographies that we break up the knee in talking to one another. Is the kneecap or patellofemoral compartment, the medial inner side of our knee, and the lateral outer side of our knee. When we do a total knee replacement, we are actually replacing all three compartments. And as you can see on the slide on your right, you can actually see the metal component capping the end of the femur bone where it says femoral component in place, and the tibial component in place on the bottom. Between, you'll notice actually that there's actually a plastic bearing. Therefore, there really is never metal rubbing on metal. I think that's one sometimes misconception that I think patients or individuals who haven't seen a knee replacement have a trouble visualizing. So that's a very nice illustration to actually show that. We get people who don't work in the OR really don't get a glimpse into what we actually do. You know, what you see is, say, the incision on the front of the knee, but what we do on the inside is perhaps the most pivotal, as one would imagine. And over the decades of knee replacement being around and available, one tenet that we've always come back to and has been one in which that we really can't ignore is that we try to achieve the right alignment. We want the weight of our body that we put through our leg to pass through the center of our hip, to the center of the knee, to the center of the ankle. And you can see even the illustration on the left, and which is diagrammatic there, and the X-ray with the straight rod and line indicated on your picture on the right. That's an X-ray with the knee replacement, that the bones don't actually follow that straight line. So inside our body, we need to find a way to actually determine what is that straight axis to truly balance the weight over those three joints. And if we can do that really well, and we can do that reproducibly each time, then we can actually have a better guarantee, if you will, or a better outcome overall in the most patients to have a knee that they can rehab and recover from, a knee that can behave perhaps more like their normal knee, and also have it last hopefully as long as possible. Therefore, the engineers that have done a good job in regards to designing the knee can actually have done so with this idea in mind, that the forces across the knee are going to be very balanced. So now enter Lantern as there's a big cliffhanger in the beginning. So I'll tell you about Lantern and Ortholine. Packed into a small device, really, that fits in the palm of your hand. It uses technology such as accelerometers and gyroscopes to actually register the patient's anatomy intraoperatively. So there is a set of instruments that allow us to mount and attach the box that you actually see pictured on your right, and teach it where that center of the hip, the center of the knee, and the center of the ankle are for that particular patient at that moment inside surgery. The technology itself isn't actually new, but I would say miniaturizing it to get it in this format has been really the tremendous advance for the technology. In fact, I've used this device throughout the years through its various iterations, and it's only continued to get smaller and faster, much like the other devices in our world, especially our smartphones. It's so amazing how much we carry around in our pockets every day. And for those of us who haven't had those conversations, or maybe haven't lived through that time, decades ago, computers used to fill rooms. So yet, like, we have it in our pocket and could probably actually navigate a device or rocket to the moon with what we have in our smartphone. All you need is an app for that. But the Lantern device and Ortholine actually allows a way in that small form factor to actually achieve reading that alignment. So that way, all of our precision cuts that get measure 3 times and then cut once, can be accurate and precise each time that we actually do the knee replacement. So for that individual, we can achieve that golden alignment, if you will. So the implant itself is the same. That isn't where the technology is, but actually having a roadmap to be able to provide those precise cuts and a feedback that actually tells me that, yes, everything is lined up the way that it should be, is something that adds to that precision. I would say, being a higher volume joint replacement surgeon, I think there's a certain level of proficiency that they've been able to show in many articles, that you have a high level of precision, and with such techniques and technologies that navigation provides, you can still actually have an increase upon what you're able to actually do with your own talent, skills, and naked eye, for sure. So the device actually, as you can see on the lower right hand of your screen, actually has a way to mount and register both the tibia bone, which is pictured on the screen, and then also the femur bone as well. And when you put the two together, it actually will provide a virtual image of that knee in real time and give us an idea in regards to what our cuts are going to do affecting the knee. In fact, in balancing the knee, as we call it, and there are questions about that, we can answer that. We can get real-time data in regards to how we might actually change our implant and bearing thickness even to produce an overall construct or overall knee that, say, bends better or has better laxity. The knee itself can't be super, super tight like a drum. Otherwise, we wouldn't be able to straighten it and move it the way that we want. So there is still a little bit of an art to that, but you want real numbers to be able to try to actually have a guide to what you do. I would like to say that you could do things by feel or do it by the force, but it sure is nice to actually have science actually helping you. So as an example, preoperative and postoperative x-rays, the picture on your left shows a very arthritic knee. We should see on a normal knee actually visible dark black gaps between the two bones. I don't know if my arrow actually shows up for you guys, but the picture on the left, you can see that the bone femur actually above and the tibia below are actually in contact there. And that is the sign that the cartilage has worn away, and that's a picture of bad arthritis. We try to restore that absolute alignment, and this is a picture of the tibial implant and the femoral implant in the proper alignment after the knee replacement. So I believe that's our last slide, Lauren.
Yes, thank you so much, Dr. Feliciano. And please continue to type your questions into the chat. We'll go ahead and get started with the Q&A, but if anything else comes up, feel free to continue to use the chat with any questions. So we'll start with the first question here. It is regarding weight loss. I know you had mentioned for your patients, for those who lose 5 pounds, you congratulate them on having 25 pounds, lost on the weight of the knee. But we have a question about a minimum weight or maybe a minimum BMI. Is there something that you're looking to be, or the patients have to look to be somewhere in order to be a candidate for a knee replacement?
Yeah, I would say weight is always a big topic, and weight is also distributed differently for various patients. But by far and large, there are standards that are set up by really the hospitals as well as the venues that we operate in the surgery centers based on articles for general safety, as well as those statistics that show us that a patient who is closer to their ideal body weight tends to have a smoother recovery, perhaps also less pain, faster time to achieving their range of motion and return to activities. They also have a lower readmission rate to the hospital for even factors that are not directly related to the knee replacement, such as readmissions for urinary tract infection and sepsis, pneumonia, things like that. So that generally are more associated with somebody's mobility after surgery. So most hospitals have actually set maximums in which that they would like patients to be under a certain BMI in order to tackle the elective knee replacement. Most hospitals and surgery centers are going to set that at 40. I tell my patients that definitely for that minimum, you would want to be under a body mass index of 40. However, for your general health and probably real success, if you look at the articles, you really would want to be under 35, or again, closer to your normal body mass index for your height and weight, which most Americans probably would settle somewhere, anywhere between 24 to 27, actually, if we were in our ideal range. So that's a big answer, but I think that I like to kind of promote at least what good health would actually be as well. So probably not shooting for the minimum all the time, but trying to get yourself healthy in the right direction.
Thank you, and thank you for explaining, the complications that you might have to look out for versus being at that healthy BMI, not only for the knee replacement, but discharging and getting back into your lifestyle and doing what you love to do before you had knee pain. We have another question here. This is regarding having pain in both knees. So, in your experience, have you seen, a patient coming in and they're experiencing a lot of pain in both knees? It kind of happened pretty quickly. And how do you address that? How do you decide which knee maybe needs to be done first? Anything about getting them both done at the same time? We just have a lot of questions about having pain in both knees. And what your take is there.
Well, in general, I would say there used to be a bigger push or support for replacing both knees at the same time if they are equally severe, both in X-ray appearance as well as how much they are affecting that patient's activities and ability to just even move around their own house, for instance. So I would say that becomes a decision where you evaluate that one particular patient. But one thing that has been accepted, though, is that there are greater complications with the knees being done at the same time, or rather in that same anesthetic setting. So someone's general health would really have to be quite tip top as far as that goes. And the perhaps effort and support needed if you have both knees affected at the same time surgically is a lot greater as well. So a lot of patients, have told me over the years that they're kind of glad that they've done it one at a time because they can focus on the one knee and get the most range of motion, the most swelling control, the most muscle strength back in one leg at a time versus some of the patients that I have done both knees at the same time. They will have a variety of different answers or recollections, but they will say that there's always one knee that's doing a little bit better than the other one. So, I would say it ends up being a decision that we'd have to take on with each patient about that. But in general, both medically speaking, as well as from a rehab standpoint, generally doing one knee at a time is probably the better way to do it.
Great, thank you. We have another specific question in the chat. This patient says that they have trouble walking around theme parks and are in a lot of pain. They've had 4 arthroscopic surgeries, and they're wondering, as a next step, should they come in to get their knee checked, or any advice you can give this specific patient?
Well, I think definitely an evaluation is the place to start. Someone who has had multiple surgeries on one knee or on both knees probably is already both familiar with their own self, as well as what information that they've acquired about their knee, even visually through X-rays and MRI with their orthopedic provider. So if it's been especially a certain amount of time, symptoms are actually worsening, I'd say it's worthwhile to revisiting an X-ray and an honest evaluation of where you might be. Will it always be surgery? The answer is no. Although as a surgeon, you'd like to say that could be yes, because I enjoy helping people and I enjoy doing surgery. But it's not always necessarily the treatment to. It's never the treatment to throw out first, but it's also not always the best treatment at that time. So any of the other injectable treatments or sometimes actually even just targeted therapy actually can be really quite good, even though someone's x-rays are moderately affected.
Great, thank you. And we do have the form and the phone number to contact Dr. Feliciano's office to schedule an appointment to be checked. We do have another question here. It's similar to your question about balance, not necessarily balancing the knee during surgery, but how does it affect a patient's balance? So We know that a lot of patients come in because they're maybe a little bit unstable, or you mentioned the comment of them leaning on their spouse or significant other. What have you seen after a total knee replacement and how it affects balance and getting back to that stability for your patients?
That hits on a number of different topics, because I think that patients at all ages, would not necessarily consider themselves early in life as clumsy. And so sometimes, coupled with some moderate knee pain or hip pain, patients notice that they are slower or perhaps more clumsy in their coordination of different
Wobbly.
movements. Yeah. And after the knee surgery, a lot of that is actually corrected in time, I would say, in the months that follow surgery. But some of that confidence in that leg is really what we translate that to say that it's confidence, but it really is that balance and alignment for the knee itself. It harkens to what patients would say when they recall prior to the knee replacement. And one of the things that might bring them into the office is that, yeah, my knee doesn't feel the best, but they notice that as their knee's getting worse, they have more low back pain. They even feel it like in their upper shoulders. They might have even had a bunch of treatment for arthritic changes in their low back as well. And when they get something like a knee replacement or a hip replacement and their balance is restored, slowly in time, like their back actually feels better. So maybe their sciatica actually has helped. So there's something to be said about achieving, better alignment overall and balance. Muscular
Great.
control would be another one. Yeah.
Thank you. And that brings us to our last question. It's actually a nice segue of the recovery time. So, what does the recovery time look like for a total knee? How long are you in the hospital for? What does PT look like? And then, second to that, when can patients get back to doing their activities that they loved, like walking around a theme park, or maybe it's cycling? What's kind of the time frame from when you receive a total knee replacement?
Yeah, that's a very good question. And I would say that my general approach to it has changed over the years. And I think changed to streamline it, much as everything has become in the mainstream. And what I mean by that is people are staying in the hospital much less than what they used to. In fact, probably a good fifth or a third of patients that have their surgery in the hospital setting actually go home in the same day. More and more patients are actually even avoiding the hospital, mainly because of their own good health, that they have the confidence that they can leave in the same day and have that also family or friend support at home that they may benefit from, say, for the first week or so after surgery primarily. So a lot of surgeries are actually becoming possible in an outpatient surgery center, even for joint replacement. So as far as hospital stays, that has really dropped tremendously in the last, I would say, 5 to 8 years or so. In regards to how long do you want to set aside block of time in your life for recovery after knee replacement? And I think that is best answered by what fitness medically and physically you have going into the surgery is a good determinant for that for coming out of surgery. Because clearly we want to build you up to your best version of yourself in regards to both your knee as well as your overall health after your surgery. And if somebody does some of the work, let's say in regards to optimizing their health, maybe even doing some pre-surgery therapy to build up some strength in the leg or in the other supporting limbs even, then I think that they have an easier time for the rehab. In general, I ask patients to say, don't schedule a lot of, say, obligations or travel anywhere from 8 to 12 weeks after your surgery. Now, can you be walking without an ambulatory aid, say somewhere around 4 to 6 weeks? The answer is sure. But again, that depends on your overall fitness, going into the surgery. And I think we'll tailor that therapy program for each individual accordingly, to give them the tools to progress as rapidly as possible through that. But in general, try not to have a lot of obligations, say like within that 2 to 3 months after your surgery, whether that be travel or just have to be the caregiver for somebody else, maybe in your family. You want to try to clear the decks for you.
Great, thank you. Personalized care for each patient. We love that, including their rehab schedule. Great. So that was the last question in the chat. If you could go to the next slide, please. We have a QR code here that scans to the form. If you scan this form, you will be contacted by Dr. Feliciano's office, and you can check off there if you prefer to be contacted via email or by a phone call. So feel free to scan that QR code. You also have the phone number that you can call directly. And I did place the link to his website in the chat, so you can feel free to go there if you'd like to learn more about his practice. Thank you all for joining us, for being great members here in the chat, writing down your questions and participating with us. We hope that you are able to find this information useful and informative to make your healthcare decisions in the future. Again, thank you so much for attending. And Dr. Feliciano, we appreciate having you here and being able to share a little bit more about your practice with us.
Thank you very much. Thank you. Thank you all for spending the time.